we will discuss the impact of cardiovascular disease and actionable solutions that promote greater heart health in our communities. And together, we will review policy-oriented solutions that can lead to enhanced cardiovascular awareness. And following the insights of today's event, we will also be developing a sign-on letter to deliver our critical recommendations to lawmakers. So more information will be provided throughout the roundtable. So before we begin, I would love to introduce our President and CEO of the National Hispanic Council on Aging, Dr. Janira Cruz, that she will be providing some welcome remarks. Welcome, Dr. Cruz.
Good morning, everyone. Thank you, Christine, for the introduction, and welcome everyone to today's Cardiovascular Thought Leaders Roundtable. I know how busy everyone is, so I really appreciate your time here this morning. Know that we will put your expertise into good use, and your advice will be recorded and take it very seriously to drive the work that we need to do as an organization in pushing programs and advocating for policies that best serve our population. And so, we come together with a clear and pressing purpose, and that is to address the critical issue of cardiovascular disease and the absolute necessity that it be addressed with adequate and comprehensive policies. And we know that existing policies have ill met the impact of cardiovascular disease and continue to hinder effective care and management among vulnerable communities, Latinos. And specifically, the Safe Step Act is one such policy that needs to be addressed. It presents serious challenges, and we will learn about the Safe Step Act throughout this morning. But the challenges associated with these type of authorizations and policies create barriers that prevent patients, especially older adults, from receiving timely and appropriate cardiovascular care. And these policies do not put patients first, and our older adults are suffering as they navigate through obstacles intended to prioritize the needs of insurance companies and medical provider profits. And so cardiovascular disease remains one of the leading causes of death in the United States, with particular regard to older adults. And specifically, Latino seniors face disproportionate burdens due to systemic inequities, limited access to culturally competent care, and persistent gaps in our healthcare system. And as our population ages and as cardiovascular disease continues to rise in prevalence, the urgency to act becomes even greater. Creating well-designed policies that address these systemic barriers is not only integral to the good health and prosperity of today's older adults, but for generations to come. And so our goal today is not only to identify these barriers, but also to propose concrete solutions to improve some of these challenges that we're facing. And so together, we aim to develop these key insights and recommendations such that the National Hispanic Council on Aging, in conjunction with all of you, can share these insights with the administration and with key members of Congress who are interested in listening to our input. So again, I appreciate you being here. Thank you, Christine, for moderating. Thank you to all the members who are here joining us. Know that your expertise, your experience, your wisdom is making a difference and will be impactful in the result of this program. So I appreciate your time and your commitment, and thank you, of course, for everything you continue to do to make this world a better place for all of us. So with that, a big hug to all of you, and I turn it over to Christine.
Thank you, Dr. Cruz, for your remarks. So first, we would like to start with the introductions of all the attendees here. So to be respectful of today's time, we would like for you to mention your name and the organization you work with. I can start first, even though my name is there, but I'm Christine Perez. I'm the Director of Programs at the National Hispanic Council on Aging. So I'm going to pass it to Dr. Paraiso.
I'm Harry Verizon. I'm the Executive Director for Perfil Latino TV, and I'm delighted to be there with you. And I think that's all you wanted to say.
Thank you, Dr. Paraiso. Who wants to go next? Or I will call the person that is next to Dr. Paraiso on my screen. That is Mr. Berilla, Alex Berilla.
Good morning, Alejandro Berilla, Arizona State University.
Thank
Happy
you,
to
Mr.
be
Berilla.
here.
Thank you, Mr. Berilla. And the next will be Ricardo.
Hi everyone, I am Ricardo Posada. I work as a media specialist for NHCOA, and I'm happy to be here with all of you, and I can't wait to hear your expertise about this important topic. Thank you.
Thank you, Ricardo. The next will be Margarita. Margarita Navas.
Hi, good morning, everyone. I'm Margarita Navas, and I work for the National Hispanic Council on Aging. And good morning, and happy to be here.
Thank you, Margarita. And the next one that I have here on my screen, it's Ms. Lindsay Miltenberger.
Hi, good morning, everyone. Lindsay Miltenberger with the Society for Women's Health Research.
Thank you for joining us. And the next person that I have here is Terry Wilder.
Hi, good morning. Terry Wilder, she, her pronouns. I work for SAGE. We're the largest and oldest LGBT aging organization in the United States, and I'm the manager of health and economic security policy.
Thank you for joining us, Terry. And the next one will be Dr. Veronica Vital.
Good morning, everyone. I'm Veronica Vital. I'm the president of the National Association of Hispanic Nurses. Happy to be here.
Thank you, Dr. Vital. And I have here Leonardo Henao.
Hi, good morning, everyone. My name is Leonardo, and I'm a property coordinator at Casares Apartment, and also work for the National History.
Thank you, Leo. We couldn't hear you well at the end, but he also works
I'm sorry.
for
Yes,
NHCOA.
that's what I was saying.
Thank you, Leo.
Mhm.
So thank you all again for joining us. And before we start with the discussion for today's roundtable, we would like to invite Lindsay Miltenberger, the Chief Advocacy Officer at the Society for Women's Health Research. Today, she will be providing an overview of disparities seen in women's clinical cardiovascular care. So welcome, Lindsay. I believe you have access to share your screen, right?
I think so. Let's try. It says sharing's not turned on. Let me send a request.
Got it.
All right, there we go. Good morning to you all. I'm thrilled to be with you here today. As the Society for Women's Health Research, which I'll get into our background momentarily, we really pride ourselves on kind of the collaboration piece. So I'm really excited to get connected with this group and looking forward to hear what comes from this roundtable and learn about your policy priorities, especially heading into next year. I know there's a lot that we can learn from you all. And so really just looking forward to the partnership here. So with that, let me go ahead and share my slides. So I've been invited today to come and give a presentation on disparities in women's cardiovascular care and some women's health specific considerations. And I'll also add a disclaimer at the beginning that our organization focuses on things that differently, disproportionately, or exclusively affect women. So it's a really broad swath. Cardiovascular health is an area that we've been involved with for quite a while, but I am by no means an expert in this space. So again, I really appreciate and look forward to learning from each of you. I wish I could stay for the full roundtable today, but I think with end of year schedules are starting to pile up pretty quickly. And Christine, I don't know if we chatted timing, but feel free to just flag me down or send me a chat when I've hit my time. Really quickly about our organization. So the Society for Women's Health Research is, we're celebrating our 35th anniversary this year. We were founded in 1990, really based on this idea that women were not being included in clinical trials. And so our founders came together and really wanted to change the culture of medical research, recognizing that women and men are different and that women needed to be recognized in research so we could have a better understanding and improve outcomes through research. So we really started as kind of a policy and advocacy organization. Our group was really integral in championing the 1993 NIH Revitalization Act, which required the inclusion of women and historically underrepresented minority populations in NIH research. We also we advocated for getting offices of women's health propped up across the federal government within the Department of Health and Human Services. So over the years, we've, kind of continued that policy and advocacy arm, but we've also kind of expanded our mission and now kind of have this parallel pillar of advancing women's health through our science policy and education program. So really continuing to promote the importance of research that considers and analyzes sex differences, but also bringing together interdisciplinary, intersector groups of people to talk about gaps and unmet needs in women's health research, and then create resources that aim to close those gaps in some capacity. Our vision is to make women's health mainstream. We kind of joke amongst ourselves that we want our work to be obsolete. We don't want women's health to be an afterthought or something that we kind of think of as secondary. Women represent 51% of the population, and so we want that reflected as such in our systems and in our research. So I thought I would start this morning by just kind of taking a step back and looking at the women's health research landscape before we kind of dive into the cardiovascular, because I do think it sets an important stage and provides an important background. So, I mentioned that we were founded because of the historic exclusion of women from clinical trials. It wasn't until 1993 that legislation was passed requiring the inclusion of women and underrepresented minority populations in research. It wasn't until 2016 that the NIH passed its policy on sex as a biological variable, which outlined NIH's expectation that research, design, reporting, and analysis consider sex. So really, if you're looking at the long history of research in this country, that is not a long time that we have been considering gender and sex-based differences. There was a report that was released by the National Academies last year that found that in fiscal year 2023, less than 8% of total NIH grant funding was allocated to women's health research. From our previous work, we had kind of been using 10% as a number. So to see NASM cite 8% was pretty bleak. And then there are some other, I think, important pieces here as well. So again, despite representing 51% of the population, women are still underrepresented in some areas of clinical trials. We've made great progress, and I think overall, the representation is about 50-50, but it depends on the areas. So cardiology is one where women still tend to be underrepresented in trials. Neurology is another area. And then the last piece here is that male animals are still disproportionately used in biomedical research. I have pretty dated study at this point that kind of examine this, but I still see different articles and news reports as recently as 2025 that talk about how there is an over-reliance on male animal models and research. And so kind of the overarching point here is that cardiovascular disease is the #1 killer of women in the United States, but our systems, from research to clinical care, were not necessarily built with women in mind. And these gaps that exist in research really shape the quality of the care that women receive today. And I'll get into this again in later slides, but what we see in clinics are the downstream effect of decades of these research inequities. We see women's symptoms are often missed or dismissed or not diagnosed. So there's really a lot here. And I'll get into that now. So as I was just saying, research gaps impact clinical care gaps, which result in worse outcomes. Beyond kind of the exclusion of women from clinical trials, the underrepresentation of women in cardiovascular trials, there are many studies that fail to analyze outcomes by sex. And as a result, often diagnostic criteria, the risk scores that are used, treatment guidelines are often based on male physiology. And when I was talking about the downstream effects, it kind of indicates that this research pipeline is a really important factor for what clinicians can know and what they do know. So rectifying this gap is critical. There's also a lack of gender-based training in schools. One of the things we mentioned in our heart health policy agenda, there was this national survey of medical student organizations that found that only 43% of students felt their curriculum gave them a better understanding of sex and gender medicine. And even less than that, only 35% reported feeling that they would be prepared to manage sex and gender differences in healthcare. So women's cardiovascular disease often looks different, but our system isn't meant to detect it, again, because we either weren't studying it or because it's based on male physiology. So again, in our heart health policy agenda, these were just some of the gaps that we found in women's cardiovascular care. Women are more likely to experience delayed heart disease diagnoses and therapeutic interventions than men. They're less likely to receive guideline-directed therapies and interventions compared to men. Younger women with heart attack are more likely to be misdiagnosed compared to their male counterparts. And they are less likely to receive cardiac rehabilitation or secondary preventive measures after a heart attack compared to men. And there are even more that you see when you really start digging. So there really is a gap here. But beyond that, there are some additional factors affecting care. So Dr. Cruz mentioned step therapy and prior authorization in her opening remarks. These utilization management policies can impact treatment for cardiovascular patients and are things that sometimes are out of their control. When I mentioned SWHR tries to bring together these kind of interdisciplinary, intersector working groups, that's something we do at the start of each of our programs. We bring together researchers and clinicians and patient advocates and policy experts to talk about the gaps and unmet needs in these spaces, to really try to get a sense from the people who are doing this day in and day out what they're seeing. And so one of the things that came up during one of our cardiovascular health roundtables was that step therapy can significantly delay access to treatments. And the one that came up in particular were the PCSK9 inhibitors. But prior authorization can also delay access to really important treatments. Another thing that we kind of cited whenever we were doing our own digging was there was a 2022 survey of AMA physicians, and a third of the respondents reported that PA policies led to a serious adverse event in care, but it could also lead to people dropping their treatment regimens or or things like that. So that's certainly a barrier that we want to try to address through policy change. There is also the factor that women comprise only 15.5% of practicing cardiologists. If you get into the subspecialties, it's even less. This was another thing that came up during our roundtable. And then there are also kind of broader systemic factors. Women, we've seen the estimates range that women represent somewhere from 60 to 66% of informal caregivers in this country. And as a result of that, women may have less time to take off to care for their own personal health. They may face an increased, you know, the physical toll of caregiving can often be really substantial for caregivers. While it's also rewarding, it does take a physical toll on the caregiver's health as well. So there just may be less time for women to dedicate to providing care. So these are just some of the things we're kind of looking at in these spaces and paying attention to. And in terms of some of what SWHR is doing to try to address these gaps and to raise awareness, you know, certainly learning from our partners and, you know, and trying to join in on policy initiatives that they're working on, anything that we can do to be supportive. We certainly want to do that. A few years ago, I think at this point, we released a heart health policy agenda. So this took insights and learnings from that roundtable and just kind of, you know, put together some of these recommendations across different issue areas. So we kind of broke it down by coverage and access and clinical care and some of the research gaps that exist, and sent that to policymakers to let them know some of what came out of this roundtable. And then we still will advocate for some of these changes as part of our broader policy portfolio. Over the past several years, we've also done this campaign called #ReadMyLips or lipids. So this particular campaign talked about, you know, really educating women about their risk for heart disease and talking about the role of understanding your lipids and being able to empower yourself and understand your heart disease risk. And then most recently, we released the first chapters of what we hope will be several chapters of kind of this Medicare guide, where we broke down, and this is a little more on the access side, but you know, a guide to help women be able to understand some of the benefits, items, and services that Medicare provides related to heart health. So we go over some of the preventive services when it comes to cardiovascular health that we think women should be aware of. There are guides in there, things to ask your healthcare providers during your annual wellness visit, just things that people might not be aware of so they can take advantage of what Medicare has to offer in terms of empowering themselves to take charge of their heart health. So all in all, that's a little snapshot of what we're doing. We also have something called the Women's Health Equity Initiative, where we talk about a few areas that differently, disproportionately, or exclusively affect women. Cardiovascular disease was another area. So on that page on our website, we have a fact sheet that talks about some of the disparities that exist in women's heart health. We also interview patients and caregivers to get stories. So we've done quite a bit in this space, but this is just a little snapshot. So with that, I can pause and happy to answer any questions. And again, looking forward really to learning from all of you today and to seeing what the outtakes from this roundtable are.
Thank you, Lindsay. So I think just for time efforts, I will continue with my presentation, Lindsay, and
Perfect.
then we will open it up for any other questions from the participants. Anna, if you can share your screen, thank you. So for today, I will be highlighting our focus groups analysis in regards to Latinos adults' knowledge, attitudes, and beliefs about LDL-C, or also known as the bad cholesterol, testing, treatment, and also the management. In the next slide, so we gathered basically the focus groups format was we gathered the opinion of over 72 Latinos and Latino adults or Hispanic adults about cardiovascular disease, but particularly about LDL-C, also known as the bad cholesterol. And we did this via 10 focus groups in California, Florida, Puerto Rico, Texas, and New York. Next slide. So when we gathered about participants' knowledge about the bad cholesterol, overall, participants aged 35 and older were somewhat more knowledgeable on the topic in comparison to the other age range group of 18 to 34 that they admitted that they didn't know much about the bad cholesterol. Some participants also mentioned some health topics that represented comorbid conditions that also were part of contribute to bad cholesterol, and they mentioned diabetes, vascular dementia, and some of them recognize that cardiovascular diseases can be acquired or hereditary. So when we're talking, we ask participants about factors that contributes to bad cholesterol. Well, they mention the overall lifestyle, especially those that have a sedentary lifestyle, lack of diet, and lack of exercise. They also pointed out that some components of the traditional Latino diets also increases their risk in developing bad cholesterol. They also identified, for example, the American diet, like eating out too much, that contributed to high cholesterol. Also, the way they cook by using a lot of oils and lard for cooking. And also, some major participants correctly identified a number of foods that contribute to high cholesterol, just like red meats, sausages, dairy products, shrimp, eggs, fried foods, among others. Even they mentioned pork and chicharrón, that's also known as pork rind, that contributed to high levels of LDL-C or the bad cholesterol. So when talking about ways to reduce bad cholesterol, well, participants focus a lot on the importance of having a lifestyle, just like dieting and exercising. And they also highlighted like the importance of avoiding fatty foods and oils, the importance of eating in moderation and having a balanced diet. And just we wanted to share with all of you that two participants from Texas highlighted the importance of education in regards to reducing the bad cholesterol. And also some participants pointed out that some barriers to physical activities, it's because of the time, lack of time and sedentary occupations like those that need to be seated for a long time for more than 8 hours in a computer or working in an office setting without too much time to stand up and leave, right? Or walk outside from their office. And others pointed out that changing one's mentality is important to develop also good lifestyle changes. And a few participants only mentioned consulting a doctor or taking medications as a way to decrease the bad cholesterol. We also had the opportunity to talk more about the experience with high cholesterol diagnosis and treatments. And here we want to highlight that some participants recognized that the first approach when lowering the bad cholesterol is diet and exercise, followed by medication. And a second approach that they mentioned that was pretty interesting to hear was about homeopathic remedies that support lowering high, the bad cholesterol. And they also mentioned the use of teas and herbs, omegas, 3S, vegetables, fruits, among others. And when talking about the barriers to treatments, well, many of them express a lot of frustration with time and some economic barriers when implementing recommendations of having a balanced lifestyle with diet and exercise. They also highlighted the lack of health insurance, uh, the lack of educations from the patient and also from the healthcare providers when talking a little bit more about bad cholesterol. Some mentioned the lack of transportation, the fear, also the hesitancy to go out to the doctor, and an overall of lack of education about the topic in regards to bad cholesterol. So we ask participants about their experiences with step therapy requirements. And basically, for this section, we had to provide like a brief description of what it was, because most of the participants have never heard about step therapy before. And just as Lindsay mentioned, step therapy, it's basically an insurance policy that requires the patient to try to lower cost medications, also known as the generic medications, right? Before it will cover a more expensive one. And as soon as we explain that term, the term of step therapy, participants view it as a practice that is unethical, inefficient, and not transparent. And participants thought that patients should be the ones that are in control on making the decision about which medication they take, or should share this responsibility along with their healthcare providers or the doctors, and not the health insurance companies. So when we talk about prior authorization, in this part here, I want to highlight that several participants were familiar with the concept, yet they were also, were hearing it for the very first time. And also participants reported a range of experience with the pre-authorization process, from minor issues like switching to insurance-approved medications to more like disruptive challenges, such as changes to their treatment plan and significant delays in receiving necessary care. And also we ask about participants' familiarity and willingness to participate in clinical studies. And next slide. And basically all of the participants were generally familiar with the concept of clinical trials, since they have heard it before through their healthcare providers or even through social media. In fact, two participants heard about a clinical trial regarding specific to cholesterol. And also, when we asked whether they will be willing to participate in clinical trials or not, more participants aged 35 and older were willing to participate, while the younger participants were a little bit more cautious in participating in clinical trials. And I provided like an overview about the findings, but for more detailed information about the focus group and also the survey that we conducted regarding cardiovascular health, particularly about bad cholesterol, you can access on the following link, and also visit our our website for more information as well. So thank you. And just next, I don't know if somebody from the participants have any questions for me or for Lindsay. Well, if not, we can continue. And before heading towards the facilitated discussion, we would like to share a testimonial from Maria Isabel Houston. She is a resident from Washington, D.C., who has shared with us her own experiences with cardiovascular health issues and also the challenges that come with it, and her own recommendations for those suffering from this condition. So let's see the video.
Hi, I am Maria Isabel Houston Murua. I live in Washington, D.C. 13 years ago, I had a TIA. The cardiologists were thinking that I have an arrhythmia, and they put a little chip in my chest. And they were looking about 6 months to see if I have the arrhythmia. The second thing that I had now, I have blood pressure high sometimes, not every day. And my primary doctor is checking that because he wants to be sure that I am safe. And that is my problem right now. I had an arrhythmia, and my doctor gave me a blood thinner. The other thing that sometimes I don't understand whatever the doctor is saying me, and I need some interpreter. And the other thing that I have to change my style living, because I have to change my food, how I eat. I have to do exercise, I have to walk more, and I have to change my style. When I had this problem, I talk immediately to my family, and they bring me immediately to the hospital. Now, I recommend to check every day your blood pressure, eat well, have exercise, and walk. And you have to live a good life.
So yes, this was a testimonial from Maria Isabel. At first, she was a little bit shy in sharing her experience, but again, sharing her testimonial to us, and also letting us know the importance of knowing when something is wrong with our body, to take action, like talk first to our family members or a loved one, and also visit our healthcare providers and keep up with our health. So I believe we will continue with the discussion. And basically, we have gathered some questions, and we hope that all of you can unmute yourself or put your video on or cameras on, and can join us in this important discussion right now. So the first question that we have for all of you is, what are the most pressing cardiovascular health challenges that you have been seeing in your respective communities? Dr. Parison, if you want to start, or Leo, Leonardo.
I'm reading the question, so
Okay, or anybody else so that I can mention
yeah, I can
yeah.
come up with something.
Leonardo or Dr. Parison, go ahead.
Yeah, really, in our community, the health challenges that we're facing are probably the same thing we're talking about. We have a lack of health coverage, difficulty to communicate in the English language, and people that don't have enough insurance to face the treatment or to have the prevention they need to have to be doing testing and all of those good things. And also a lack of education about cardiovascular disease. Like we had previously listened to the lady that was talking. Yes, she was a bit shy at the beginning, but in the last intervention, she pinpointed exactly what we should be doing. Walking, eating well, and then following whatever your doctor recommends. So I would say in a summary, in my community, what are we having is a lack of insurance and then a lack of education about cardiovascular disease. Yeah.
Thank you, Dr. Perizon. Anybody else?
I could go, if
Go
that's
ahead,
okay.
Gerardo. Sure.
Good morning, everyone. As Christine said during her presentation, one of the biggest issues that I could see at Casairis as a property coordinator is, I think, it's their diet. I think as Latinos, we have a hard time trying to move away from this food that we've been eating since we were kids. And I had the pleasure to enjoy their meals because sometimes they bring me some of their food to the office. And I could tell that sometimes this food might contain a lot of fat and things that it might not be good for them. So I feel like that, alongside with the lack of knowledge or of the language barrier that they might face in this country, can contribute to a lot of cardiovascular issues in the community.
Thank you, Leo.
I think that part of the issue, and I'm not a medical specialist, so this is pretty anecdotal from people that I talk to in our community. I am an educator. Is an over reliance on non-medical things. My grandmother did this, and she lived until she was 80, and so I'm going to take some soup with herbs or whatever it is. It's an over reliance on those kinds of cures that, in addition, of course, to the lack of insurance, really cause people to just tune it out and live their life in the easiest way possible.
Thank you, Mr. Perilla. Yeah, I agree with food, the high use of oil. Also, sometimes we don't have enough time to cook our own meals due to our work or other, things that we need to do in our personal life. And it's simple to eat just outside and eat from fast food. And sometimes that can be a challenge for one's health. And I think also I want to highlight the importance of caregivers that are mainly taking care either of a loved one that would be like a family caregiver or a paid caregiver. That's the one that always is taking care of an older adult. And basically they're also part of the older adults taking their own medications, trying to have a balanced diet or eating healthy. So they also are an important asset to the older adults' health. And a lot of older adults rely on caregivers. For example, here, many of them don't have family members, so the caregiver will be the main source of information from the older adult side. And I don't know, Ms. Wilder, if you want to highlight something else, and Dr. Vital, any challenges that you haven't seen in your community?
I mean, I think the biggest main challenge, if you want to call it that, we work with older people living with HIV, and there is a disproportionate risk of cardiovascular disease in people living with HIV due to the nature of the disease being an inflammatory disease and the meds that folks have to take. So I know that's a huge concern for folks who are older living with HIV. And I know like the NIH has looked at it, and there's certainly cardiovascular doctors that are specializing in this area for people living with HIV. So I think that's one thing that came to mind as I was listening to folks, particular to the community that I work with a lot.
Thank you for sharing this information, Ms. Wilder. Anyone else? Lindsay, Dr. Vital? Or you can write it in the chat. Either way. Okay, so we will go with the second question. That this one is a little bit more interactive, and I believe it's a poll question. So the question is, what barriers do individuals in your community face when trying to access cardiovascular care? I believe the poll question will be right now, right here. It will be the first question only, like what barriers do individuals in your community face when trying to access cardiovascular care? You can choose more than one. And we have one of the options like limited access to specialists, like cardiologists, limited awareness or understanding of cardiovascular disease, the lack of health insurance or high out-of-pocket costs, language barriers, or all of the above, or you have any other that it's not mentioned here, you can write it in the chat. We will give you like 1 minute so you can reread it and choose.
Do we need to write our answer on the chat, or we can speak
Yes.
up?
Whichever you prefer.
Okay.
You can speak up.
Okay. Yeah, I think all of the above for me.
Yeah, me too. And more, right?
Yes.
You can answer only the first question because the second one is for another questions that we're having later on. Or if you have others, you can say it out loud or type it in the chat, whichever you prefer.
Some others that I might flag are kind of the more systemic barriers. So for example, if people are trying to receive care, if they're enrolled in a cardiovascular trial, but live in a rural area, making sure they have transportation to that clinical trial site. I mentioned caregiving during my presentation, but if somebody's serving as a formal or informal caregiver, they may not have the time to be able to take away, making sure they can take off of work. Some of those kind of factors I think are also really important.
I agree. Thank you, Lindsay. Okay, so basically of what all of us have shared will be all of the above, including the limited awareness of understanding of care, Also, language barriers, lack of insurance, limited access to specialists, and other that Lindsay mentioned. Any other comments that any of you want to highlight as part of the barriers that you have encountered or know from the communities you serve? If not, we'll continue with the third question.
This is
And
Veronica. I apologize.
go
Sorry, I
ahead, Dr.
finally am
Vital.
able to respond. I apologize. But yes, I also think the social political climate right now has been really impacting our communities. Even if they have those, barriers, the other barriers taken care of, like transportation and stuff, they still don't want to go to the clinics and stuff or go receive the care right now because they don't know what could take place while they're there in the process. So that's just been a challenge right now. So some people are choosing not to go to the clinics and get their care, or their doctor's offices. So that's been a challenge for our communities.
Thank you, Dr. Vital.
Mhm.
Okay, so our third question is, this is more about what we have been hearing in regards to step therapy and authorization requirements. So how have step therapy and authorization requirements impacted timely access to cardiovascular disease medications?
I'd like to listen to what some other of the panelists are saying, because I don't have any experience with step therapy. So, yep.
Basically, what step therapy is it's like like your healthcare insurance, that sometimes, for example, you go to your doctor and they prescribe you a medication, and when you go to the pharmacy, they give you a generic medication. And basically, that's what step therapy is about, an insurance policy that requires the patient, right, to try the lower cost medications first to see if it works. In this case, will be the generic medications before it will cover the more expensive one that is the one that sometimes the doctor prescribed. Sometimes it works on the patients, but on the other part or other end, it doesn't work at all. Sometimes this process of takes a while, and can be harmful for the patient. Dr. Chris, you can
Yeah.
go next.
Just thank you, Christine. And just to add to what Christine just said, so step therapy, it's also called fail first therapy. So it's an insurance requirement that essentially forces patients to try one or more lower cost preferred medications before covering a more expensive one that is prescribed by the doctor. So essentially, it's a way to save money. And the insurance forces patients and the system and the doctors, medical providers, to try a cheap version first. If that doesn't work, if those cheap versions don't work, then they will try the expensive medication. But oftentimes that could be too late. It could be that the person lost the opportunity to save their lives because time went by and the whole step therapy process took too long.
Understood.
Thank you, Dr. Cruz. And also, Lindsay mentioned that her organization has supported the passage of the Safe Step Act, which would make reasonable modifications to protocols such as establishing a medical exception if delaying an effective treatment will lead to irreversible consequences. Thank you, Lindsay. We have done the same too in supporting the passage of the Safe Step Act.
Great. And I sincerely apologize. I have to run to an 11 o'clock, but again, looking forward to hearing the takeaways from this. I wish you all a successful rest of your roundtable.
Thank you, Lindsay, for joining us.
Christine, if I may,
Sure.
on that last point you made, did you say that NHCOA has taken action on the Safe Step Act or not?
Yeah, we have supported the act
Okay.
through sign-on
Thank you.
letters and also via our report that we have
Got it.
supported it.
Okay, thank you.
Sure. I don't know if Dr. Vital, do you want to highlight something else?
No, not at this moment. Thank you.
So we can continue with our next question. That would be, can you share what your organization is currently doing to address cardiovascular disease overall? Like, for example, through education, prevention, or access to care, or any advocacy efforts.
We have a program, Su Corazón, Su Vida, that we've been doing since back a few years ago. We continue doing that, and what we've been doing is having workshop on chronic disease and especially cardiovascular disease. We also have runs ad on TV about cardiovascular disease prevention, or how to manage your heart disease. We have also done workshop about informing people about low cholesterol diet, low fat diet, and then that's what we've been doing to address cardiovascular disease.
Thank you, Dr. Parizon. And that's impacted all of the population, right? Or the age groups.
Yes.
Sounds good. And Leonardo, do you want to highlight some of the efforts that Casa Iris housing facility have done?
Yes, of course. One of the big programs that we have in the community is that the residents get PE classes every Monday, Wednesday, Friday. During these classes, of course, they do stretches. They sometimes do some walks and there's always like movement activities that benefits them. And on top of this, they also get screenings and they get monitored during the week. So the teachers have a control over their health, and every Monday they take their blood tests, they take the pressure, and they do other tests just to make sure that they improve it. And we have seen a big change, and this program is extremely important for residents. They do love it, and it have changed their lives, and also the diet, because they get a lot of useful information during these classes too.
Thank you, Leonardo, for sharing your insights.
Of course.
Dr. Vital, you can go ahead.
Hi. So currently, the National Association of Hispanic Nurses, we just went through a training with the American Diabetes Association to get trained on through the obesity masters trainers. And so we're excited about that to be able to be a part of that. So we will actually go and disseminate information across the nation with our because we have 46 chapters across the nation. So we will be doing kind of like train the trainers, and we'll be going and disseminating this information and tying it into cardiovascular health as well. So we're excited about that. So not only will we have our nurses trained across the nation, they'll be actually going into the communities and disseminating this information at, health fairs or different events that they're doing across the nation. So we're excited about that, along with, having our other members who specialize in cardiovascular health. So they tend to do presentations for our members as well. So just really trying to increase the awareness of cardiovascular health out there. So that's some of the work that we're doing through NON.
Thank you, Dr. Vital.
You're
That's great
welcome.
news. And amazing too. A trained trainer.
Thank you. Thank you.
Mr. Perilla, do you want to share some comments? If not, mm,
Not sure. I mean, again, these are personal experiences, and I'm not sure how helpful
okay.
they might be to the group.
I think that would be extremely helpful.
Yeah. Look, I have cardiovascular disease. It's been a challenging journey for me. I think that I mean there's no lack of education. There's no lack of health insurance. In my case, it's been as with many others. It's a challenge that's progressive, and that you begin to face slowly over time. There's no magic to having difficult circumstances happen and then all of a sudden there's an awakening and you're on the right path. It's a battle each and every day to do better. Unfortunately, the reality of the disease is that there's no immediate cure or even a long-term cure, but you still have to be willing to do the things that are necessary to be healthy, and that's a very difficult message to communicate with people. I don't know that the medical community really understands that. They seem to say, if you do these things, you're going to be fine. And that's just not the fact. If you do these things, you're going to hopefully continue to be alive, but the disease won't go away necessarily. And I think being forthright about that is really important.
Thank you, Mr. Perilla, for sharing your testimonial.
You bet.
So let's continue with the next question, and is what specific support or tools, policies will help you strengthen your cardiovascular disease in regards to your work or in your personal side?
This is Veronica. I think organizations are doing a great job of trying to get the awareness out there. I think being able to find a way of really having all the tools, all the support, these things in maybe like a one um, platform so we can utilize them, being in different languages, and the consistency, the message that's going out there. So that to me, I think would be optimal is, just having like a hub or having something that we can really access to provide for patients, provide to the community. That way it's accessible for our members across the nation. So that's like my dream, my goal is to having that a hub or something, for us to utilize.
That would be amazing too.
Right.
To have it. Yes, I agree. And I want to also highlight the importance of developing like culturally and linguistically appropriate materials, or when providing education to our community, for example, by using promotoras de salud or community health workers that know best their communities. They are trusted messengers in their communities, and a lot of their community rely on them in regards to information, to tips, or any guidance in regards to any health issue. And of course, the promotoras de salud are well trained around cardiovascular health overall, and they can also guide them, but at the end, they know that they need to go to the doctor, like encouraging to visit their doctors or a community health center. So this is very, very important to highlight the promotoras. And also the funding. I think funding opportunities are greater now than ever. And this help us to continue with our work and amplifying the reach to more people. So funding, it's a very important piece to also highlight. I don't know if Dr. Paraiso. Oh, Dr.
I would
Chris, go
say,
ahead.
I was going to say, I would say that one of the things we need in order to encourage legislators to pay more attention to this type of situation and challenge in the health space is having more human stories, that we can, that can show the human impact as a result of the current policies that are getting in the way of providing effective and timely care. So I think more of this type of work that we're doing right now, where, we'll be able to communicate to policymakers sort of through focus groups, sort of help them take the pulse of what people are experiencing, hopefully will humanize the numbers and humanize the issue. And, with that compassion, we can create some change at the policy level.
Thank you, Dr. Cruz.
I agree with everything that have been said, but I think emphasis on the human story is a great, will be a great tool, because people listen to other people's stories. They relate when somebody is telling them, oh, I had experienced this problem. This is what happened to me. And then there are many cases that we need to increase awareness of people listening to their body, because the heart is a very noble muscle, but it gives you some signals that, hey, I'm not doing too good here. You have to take care of me. So if we do some kind of a campaign, hopefully we have some funding, as you were mentioning, Christine, that are very important for us to do this kind of work. But we can publish many stories of somebody that has suffered from cardiovascular disease, what they have done, and also what they have done to prevent something like a heart surgery or something. Are they doing the steps to take care of their heart and be better? So the stories will be very impactful.
Thank you, Dr. Paraison. Anybody else? Leonardo, do you want to highlight something else?
Not at the moment. I don't think I have anything else to say about this question.
Okay, thank you, thank you. So let's go to our next question, and I believe that's the last one. And we will have it interactively as well via poll. So the question is, looking ahead, what is one action you would like to see policymakers, public health leaders, or funders to take better support of community level efforts to prevent and manage cardiovascular disease? We have several options, including like the increase of funding for community-based prevention programs, expanding access to affordable healthcare and medications, enhanced screening and early detection programs in underserved areas, all of the above. Or if you have others, you can write it in the chat or also unmute yourself and you can let us know via Zoom as well.
All of the above.
I knew you were going to say that, Dr. Paraiza.
But they're all very important. So
Yes, I agree.
it's almost a no-brainer.
Exactly. And also the commitment for the policymakers to continue their work in regards to not only the Latino, but all other underserved communities as well.
Mm-hmm.
If you have others that are not mentioned in the options, you can let us know via Zoom here. Yeah. Yeah, all of the above. Thank you all. I don't know if Dr. Vital, Alex Perilla, do you want to mention any other action that you would like to see?
I just to support your statement on promotores de salud. I am so in favor of that. The organization that I lead at Arizona State University has served about 200,000 people in the last 20 years. Doing things in writing for them is much less helpful than putting somebody that they know and they trust in front of them to talk to them about whatever issue it is. And so, you know, good for you. That's exactly what we need. That's exactly what we need.
Thank you, Mr. Padilla. Just before closing for today's roundtable, anybody else has any other action that you would like to see, or you can write it on the chat or let us know here via Zoom. Well, if not, that would be all for the discussion. This time around, we made it short with this question. So thank you again for sharing your input, testimonies, knowledge, and also the commitment in raising awareness about cardiovascular disease within our communities and also its impact on older adults. So again, using the insights of today's discussion, our plan is to draft a sign-on letter, as we mentioned earlier at the beginning, that will have valuable recommendations for lawmakers in regards to improved awareness, prevention, and treatment of cardiovascular disease. We all hope that you can join this letter. So more information will be provided soon via email. And also, we want to invite you to follow us in our social media platforms, where you can find us using the handle of @NHCOA. And that would be all. So thank you again for joining us. And we look forward to continuing working together. Thank you.
Yeah. Thank you, Christine.
Thank
Thank
you.
you, everybody.
Thank you
for
so
your
much. Thank you.
participation.
Thank you. Bye-bye.
Thank you. Bye.
Bye-bye. Thank you.
Bye.